Hey Pulse Bodies, we are taking the show on the road. Well, I am. George is currently in Europe, so he won't be joining us in person. But Charlotte Blees of Dr. Bot fame is visiting Australia, and we are launching her book in Sydney on Tuesday the 3rd of March at 6 p.m. for a 6:30 start at Glebe Books in Glebe. And in Melbourne, we are doing a book launch on Tuesday the 10th of March at 6:30 p.m. at Mary Martin Bookshop in Southbank. Now, these are small, intimate venues, really a great opportunity to meet Charlotte, get to chat with her, to ask questions, and to listen to what she has got to say. Charlotte's book, Dr. Bot, on the future of AI and medicine, has become a bit of a global sensation, really. So please come down to Glebe Books in Sydney on the 3rd of March or to Mary Martin Bookshop on the 10th of March. It's going to be a really good time, but you must get your tickets. Please do not wait until the day before. You won't get in. So get your tickets as soon as you can. Now on with the show. Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. This is our Hot Topics show and I'm your host, Louise Schaefer.
And I'm your other host, George Margellis.
George, I'm a little bit jealous. Tell us all what you're doing today.
We've actually brought our recording forward a day or two because I'm about to jump on a plane and head off to Europe for a couple of actual digital health events. So I'm heading off to Athens Digital Health Week, which is being run in conjunction with HL7. Interestingly, following our recent interview with our good friend Graham Grieve, they're running a 2-day FIRE workshop at the event. And we'll have speakers from throughout Europe speaking around the various initiatives that they're doing using FIRE, including the European health data space. And there's interesting discussions around patient empowerment and, shock horror, Louise, they're even talking about AI.
What? No.
Who would have thought that would have got onto a conference program? It's a really packed 5-day event. It's being held in the heart of Athens at a beautiful hotel. And guess how much registration is?
I don't know, a few $100?
Zero. Free registration.
Who's paying
I don't know
for it?
how they're going to do it. I'll let you know. Whether the Anastas family is interested in health, I'll find out. But it's a free event with 4 concurrent sessions running in a beautiful hotel in downtown Athens. I might even end up getting some ouzo and souvlaki while I'm there. I'll let you know. I'm excited about attending. I've been to Greece a number of times. The Greek health system has its challenges like all European countries, but they've been doing some significant progress. But I'll be interested to see what's happening there. So I'm looking forward to that.
Oh, that is going to be so good.
Yep.
Okay, well, I'll be watching out on LinkedIn for posts
definitely.
and look for people that might want to come on the show.
Absolutely.
To talk about.
And then I'm off to Barcelona for the Global Health Connector Summit, which is part of the huge Mobile World Congress, which is a really big event, but we sit in a separate part of it. It's running in conjunction with the European startup community called 4YFN, which stands for 4 years from now. It's an interesting group of startups. I've been attending that now for a number of years. The most exciting thing about that event for me this year is that they're using that event to launch globally the Asia Pacific chapter of the Global Health Connector. So there was a soft launch in Singapore a couple of weeks ago, but they'll be using this as a part of the global launch. And whilst it's based in Singapore beats us out again for headquarter status. Australia will play a significant role in that. So again, something we'll be keeping our eyes on for the next couple of weeks. And then in between those two events, having a bit of rest and relaxation in Athens. Now, this is Carnivali season in Greece. This is the week before Lent. And Carnivali actually in Greece, I didn't realize the last time I was there, is a big deal. There are street parades. There's concerts on in the middle of Athens. There's a whole bunch of stuff. So
I remember you talking about it last year. It sounded so fun.
It blew me away last year. So we actually coordinated our trip very tightly this year to make sure we were there for the Carnivali thing. Yep. So that's my plans.
2 conferences, Carnivali.
Absolutely.
Catching up with family, I guess.
Exactly. Drinking lots of ouzo. Nice. What they call in Greece is, I think we discovered last time we were there, inomelo. So it's actually honeyed wine that is served warm. It's like a mulled wine. It's really good. If I can find the bottle, I'll bring it back with me.
Oh, nice. I'm very jealous, George, and we'll have to work out the logistics of recording while you're away in all those different time zones.
Thank God for the internet. And yourself, Louise, how have you been? You've been pretty busy the last couple of weeks?
Oh, it's so boring in comparison. But yeah, no, I have been very busy. And actually, March for me is looking crazy. I think I'm going to be home. I've got a couple of weeks in March where I'm going to be home for one night and then I'm on the road the whole time. Oh, one of the things I'm doing in March, which is going to be really fun, is Greg Moran and I are back with RACGP with the hackathon. So I look forward to reporting how that all went. But that's the weekend of, starts Friday, the 13th of March in Sydney. So RACGP, after the success of last year's hackathon, they were swamped with GPs and tech people and people just wanting to help. And yeah, it's going to be fun. Although, George, the only thing is when they asked me, I was like, oh yeah, that's an easy yes. I'd love to do it. And it's over a weekend. So, I'm not really going to have other plans. It turns out I do have other plans. I bought tickets to Faithless. Do you remember in the 90s, Insomnia? Like, I can't get no sleep, that dance. Anyway, it's awesome. And it's 30 years old now.
Retro is in, Louise.
Retro is in. Anyway, and so I was trying to work out whether I could leave the hackathon on time at the end of the day, fly back to Melbourne for the concert. And it turns out, no, I probably couldn't do that. So if any listeners want a couple of tickets to Faithless on Saturday, the 14th of March, I have 2 tickets and I don't have any friends that want to go. Anyone wants to go, let me know. I'm thinking maybe I could go see them in Sydney because they're playing in Sydney on the Friday night. Could I leave the hackathon and just have a 20-minute tram ride over to Hordham Pavilion? So we'll see.
I think that should be on your agenda. So you're going to be up here for the healthcare week as well, the beforehand, or?
Yes.
So we'll have you in Sydney for almost the whole week. That'd be great.
Yeah. That week I've got Canberra, Asthma Australia. We're hosting a International Women's Day event there. Kathy Freeman is going to be there. She has asthma. 2 health ministers have agreed to show up. We've got all these people coming. So I'm doing that. That's on a Tuesday, flying back here, having a chat with Charlotte Blees at the bookstore. Everyone, get your tickets for the Sydney and Melbourne events. We've got links in the show notes for the chat with Charlotte. And then the next day I've got to go back to Sydney. And I'm there for 5 days or something.
Cool.
Yeah, so it's going to be good. Sorry, you won't be there, George.
I will be back by then. I'll be back. Yes, so I'll be back for Healthcare Week. Yeah, you touched on our good friend Greg Moran. I've had the pleasure of working with Greg a lot recently with Aging Australia, and gee, he's good.
Yeah,
he's really good. I have to take my hat off to him.
And he makes the things look so easy that other people would struggle with. He's just like, oh yeah, no problems.
Yeah, no, he's a real pleasure to work with. So shout out to Greg Moran if you're listening.
Yes. Well, I know he does listen to the show. So now he's probably flushed and embarrassed that we've mentioned his name. Okay, Greg, we'll stop talking about you. All right, George, shall we get to our hot topics?
Let's go.
Today, we are starting with a major policy shift here in Australia that could fundamentally change how we manage medication safety. Health Minister Mark Butler has announced plans to move towards a national medicines record, requiring all medicines prescribed through online platforms to be uploaded to the My Health record, including the clinical context for prescribing. At present, medicine safety often falls to pharmacists who need to make dispensing decisions with incomplete information a lot of the times. But that fragmentation has grown, with prescribing now happening across so many different professions, and then also both within face-to-face consultations, telehealth and digital platforms. And that can have really serious consequences for patients. These reforms were driven by the tragic death of 24-year-old Erin Collins last year in 2025, who overdosed after stockpiling medications prescribed by multiple digital health platforms that were operating in complete silos. Her My Health record actually did contain warnings from hospital staff, and her care team had set up daily supervised dispensing. But of course, if you're not within the system, you don't see any of it, and the online prescribers never saw any of those warnings. Now, the RACGP and the Pharmaceutical Society of Australia have strongly backed these changes, calling them essential for patient safety. George, I was thinking about how young I was when I got into this field and everything was new and exciting. I remember, I think one of the very first conversations I had was with someone saying how we don't know what's prescribed by other doctors. And I was like, what do you mean? So this idea of a national medicines record, it's been recognised for at least 20 years. Are we finally fixing that fragmented medicines data?
Yeah, you're right, Louise. This is one of the very early points of discussion before it was even, we had the concept of a personal health record. So, and My Health Record, to its defense, has been a fairly useful tool for medication management, but it does have a lot of shortcomings. It reflects, and Minister Butler said this in public, I think it was the year before last in Melbourne, that the current My Health Record is a shoebox of PDFs, and that was particularly true for medications.
Yeah.
There's lots of medication records that have medications being dispensed, but it's a standalone PDF file which lists the name of the drug, the dose, and the prescriber, and very little else. And to actually look it up was difficult. It was very user unfriendly, and you could import a whole bunch of single files, but it didn't give you much more information other than, Mrs. Jones picked up the particular script for a particular drug at a particular pharmacy on a particular date, prescribed by a particular doctor. No idea why. The fact that we're now looking at a much more detailed records portion is important. I think it's very sad that digital providers were the impetus for this move due to the death of the young girl you mentioned. Yeah. Ease of use and access does have its downsides. And whilst I know there are many reputable online providers there, the old move fast and break things motto used by digital innovators can have some consequences. So we need to take that into account. And to the government's credit, they've done that. The problem goes beyond just the medication record, but I think this is a really important first step. But when you really look at why people are using online prescription services and whatever, it's because our primary healthcare sector is under a lot of stress. And so that makes digital providers much more attractive compared to waiting 4 days to see a GP and having a $50 out-of-pocket expense and being in a churn system which doesn't have that sort of delivery of care that we would like. So I think we need to think about this in the greater context of our healthcare reform, but actually having a standardized medication chart. We did this about a decade ago in aged care. It took 6 or 7 years to get implemented, but we actually mandated a specific electronic health record format for medication charts in residential aged care, very high risk population.
Oh, and that's universal then?
And that's universal now, and it works across the system, and you can follow medications. And again, these are people who often have 5 or 6 different healthcare providers managing them. So the concept,
and multiple medications. My dad, I think my dad was at 15.
Yeah, try. The pharmaceutical companies do love Australia. Yeah, so this is going to be a good thing to be part of our broader healthcare reform, which we talk about often on our podcast.
Yeah, I used to lecture at University of Melbourne, and I would get a guest lecture. So someone from the health sector, from digital health, and Andrew Cording from St Vincent's Hospital, pharmacist there, he would come in, and every year he would talk about medication errors within St Vincent's. And this is not a St Vincent's problem. This is just all hospitals. And he would talk about all the medication problems that happened, the near misses, people almost die, people have bad consequences. And you see the students' faces, just their mouths agape, because it's like, what do you mean this happens? And for this story, I had a look at that data, and the most recent one I could find was a peer-reviewed study from 2022. But that study said about 3% of all hospital admissions in Australia are medication-related, 250,000 hospital admissions annually. And a lot of these, probably about 2/3, the literature estimates, are actually probably preventable. So this is a massive problem that we've had data on for a really long time. So excellent that the government's going to be addressing it.
I remember back in the day, Kaiser Permanente has obviously an integrated medication record within their cohort of patients they have in California. And when the Vioxx issue was first raised by the fact that they actually had access to that information within their system, could correlate it to adverse events, and found out that Vioxx was causing heart problems in older patients purely because of the fact they had access to that information. So this goes beyond just being a money-saving tool to prevent repeat prescriptions. This is actually a quality and safety tool. And the reality is, one of the things we often see in older patients is that they have a regular GP, they get their medications, they come down with a bit of a chest infection or something. Their GPs, they can't see them very quickly, so they go to another GP, or they may even go into an online service. They get prescribed drug A, B, or C without knowing, because like you said, they're on 15 drugs. They haven't quite told the new doctor that all 15 drugs, because who can
remember?
Exactly, who can rattle off 15 drugs in a 5-minute consult? And then they end up in hospital because the drug they're taking interacts with one of the other drugs they're taking. Drug interactions, we've been able to monitor those things for decades now. The good old medical director and best practice have been doing that for a long time. But you need the information. Without the information, you can't monitor those quality and safety improvements. And I think we've got a real opportunity here for us to take a big leap forward.
Yeah, I completely agree. And the idea that you're the person who prescribed medicines, but they don't know if patients actually fill those prescriptions. Some of the smart tools that could be built now, things like early warning systems. So if a patient suddenly stops filling a critical medication, could be an antidepressant or cardiac meds, that sort of thing. And I think it'd be really interesting to see over time what happens to people who are prescribing drugs, knowing what the dispensing data is, how does that change their clinical practice? And of course, we don't know that because we've never had the data before. So this is going to be really fascinating for researchers as well and what we can learn.
And look, we do have, so dentists can prescribe now, the optometrists can prescribe. There are multiple, and people get access to drugs in multiple ways. So again, one of the things we need to do here, of course, is also have the patients or the individuals actively engaged to make sure that record is accurate. Are there things they're taking that aren't on that system? Because I only know what I've prescribed. I don't know what everyone else has prescribed. And I've seen some fairly horrific examples of people being given a mild painkiller, which ends up being endone or codeine. So you need to...
Yeah, they're not great. And I was thinking about it because in the US, and we've mentioned it on a previous show, there's actually a bill in Congress. It's called the Healthy Technology Act of 2025. Congress is considering it. If they pass it, it'll permit AI systems to prescribe medications without human sign-off. Like, we really need this medicine's record database, especially if there's no humans in the loop except the patient.
Yeah. Look, and again, the AI with the right governance is probably okay to do that. But the problem is, as we've often seen, is that some of these tools get taken aboard and then leveraged to increase revenue in unforeseen ways. So I think we've seen examples where AI can actually probably manage prescribing better than some doctors, but at the same time, it has to have that proper governance about it. So that human in the loop is important, at least in the beginning, but ongoing assessments is part of it. And look, let's be honest, some of the US acts have been groundbreaking in that they've really transformed how healthcare is delivered, but not all.
So we'll keep a watching brief on that one. So yeah, well done, Australian government, really showing that medication safety is not just a really important public health problem, but this announcement means they're really seeing a national medicines record as a national safety infrastructure. Now, the timing on this, the first phase is going to ensure that medicines-related information from all prescribers is available through My Health Record by default, and consultation is currently underway, and implementation is actually targeted for December 2026. So we'll be reporting on this before Christmas, hopefully, that it's all done. Well, the biggest part of it will be done. Now, our next hot topic, George, comes from a study published in Nature Medicine that blows me away. An AI that can predict 130 diseases from a single night of sleep data. Now, if I didn't say that was in an academic peer-reviewed journal like Nature Medicine, people would be like, yeah, right, one night of sleep, as if. But no, it's legit. So what do we know about it? Researchers have developed an artificial intelligence model called sleepFM. It's been trained on over 585,000 hours of multimodal sleep recordings from about 65,000 people, and they've extracted rich physiological patterns across brain, heart, muscle, and respiratory signals. So unlike traditional sleep studies that look at isolated measures like sleep stages or apnea, sleepFM learns this multimodal representations of sleep that capture the interplay of multiple body systems. Now, crucially, from just one night of sleep data, sleepFM, as I said in the headline, it can predict the future risk of more than 130 diseases, things like dementia, heart attack, chronic kidney disease, mortality, with strong accuracy. Now, we've known for a while now that sleep is not just restorative downtime, but it is a window into long-term health and probably even a determinant. But this study shows that AI can unlock predictive signals hidden in complex physiological sleep data. And this is personal to me because I always jam so much into my waking hours that I limit my sleep. And I've been trying to improve, and George is often telling me off for it. And you're 100% right. I'm trying to get better. But sadly, I must admit, I still struggle. I am getting better, but I still struggle. And then I read this and I'm like, oh man, I'm so screwed. So are you a good sleeper, George?
I have to admit, I am a pretty good sleeper. I do have the tendency to fall asleep on the couch while watching TV late at night, but I must admit, I now try to focus on getting a good at least 7 hours sleep a night. There's a lot of research suggesting that future brain function is related to sleep. Sleep is much more than just a restorative thing. There's actually some evidence now that lymphatic system of the brain flushes during sleep. So it actually makes a big difference to brain health. Having said that, now this article has grabbed a lot of attention. Typical AI article hyperbole. Some people have grabbed it and said, here you go. All you need, 1 day of sleep data, and we don't need doctors anymore. We'll tell you exactly what you're going to have. So I actually went and downloaded the original article. So a big thank you to Nature Medicine. Nature Medicine is a great publication. Credit where credit is due. It does publish a wide range of articles. It makes most of them available for free online. I also have to give a shout out to Dr. Eric Topol, one of our past guests. He did a good analysis of this article online.
He used AI to produce an image.
He did. He did. He does some amazing stuff. It really captured the article. Now, so I downloaded the article, and it's a fairly long article. It's got a lot of mathematics in it as well. So they describe the model they use. But when you dive deep into the discussion, there's an interesting quote, and I'll quote it verbatim because I think this is really important for people to take into account when they hear these sort of hyperbole. And the authors themselves state, despite these promising results, several limitations should be acknowledged. Although our data set is large, it consists primarily of patients referred for sleep studies due to suspected sleep disorders or other medical conditions requiring overnight monitoring. This selection bias means our cohort is not representative of the general population, as people without sleep complaints or those with limited access to specialized sleep clinics are underrepresented. It also then goes on to say that interpreting the predictions made by Sleep FM is inherently challenging due to complexity of the learned features during training by this deep model. Now, what that basically is saying that the data they used for this study came from people referred for sleep studies. So, Louise, do you know who almost always gets referred to sleep studies?
Men.
Fat old men like me. Fat old men like me.
Actually.
Fat old men like me are the reason ResMed and the other CPAP suppliers are rolling in gold, because for us to get a CPAP machine, we have to have an overnight sleep study. So here we have a study which has analyzed 65,000, and I'm sure not all of them were fat old men, but I'm sure a significant number of them were fat old men. And you know what fat old men are prone to? Disease. Isn't that surprising? Now, I was surprised that I am prone to 130 unique diseases.
That's a lot.
That's a bit challenging, but the reality is you need to take these sort of studies into account and look into what they say. I mean, the authors themselves specifically say, this is an early study. It has very defined use cases. It does provide basis for other things, but we don't need AI to predict that we're all going to die one day. That's something we can do without AI. And chances are, if you hit 85, you will have a whole bunch of diseases go along with it. What we need to do is work out how to solve that problem. But kudos to the authors. They've done a great study. They've published it. They've openly discussed the issues with it. They've laid the groundwork for future research. They've even put in some really detailed maths for those of you who are using it. My concern with these sort of studies is that I don't want to open up the Sydney Morning Herald next week and say, come in, do your overnight sleep study. We'll predict your 130 diseases. We'll sell you some protein tablets and some peptides and some other snake oil and solve all your problem for only $1,500. Yeah? These are the sort of problems we need to think about, the unintended consequences of some of these studies. And that's why we need good science. We need people who look at these studies and talk about them openly. And I think that's what our podcast is here for.
Absolutely. And thank you, George. That was a really interesting analysis. And all I'd say that I don't know whether it's just because I'm a data geek, but I just love that our bodies are giving off signals. We just don't know how to collect that data or what to do with it. Certainly the study said as well, this isn't stuff you're going to see in your Apple Watch anytime soon. Like they had medical grade, basically industrial stuff attached to these people to measure all this stuff. But yeah, the possibilities of what we can be learning if we can work out ways of gathering data from large sets that are representative and what we can do with that data now thanks to AI that can churn through it so much quicker than a human ever could.
There's that famous quote, the AI we have now is the worst it's ever going to be. It's only going to get better. So we need to do these studies. This research is important, but that scientific process around the analysis of it and its use is also important. There's a lot of stuff happening in this space, but we need to also put it in the context of what does it mean for people in the real world. And if this is just going to tell people that, you're old, fat, and getting older and fatter and unhealthier, that's not a good thing. Now we need to work out how to say, now here's how we stop you from getting older, fatter, and unhealthier.
Yes, older is fine, but we'll take out those other qualifiers. All right, time for a quick break. And when we come back, we have a couple of really interesting hot topics out of China. We kicked off 2026 on the pod with a huge two-part show breaking down why GenAI direct-to-consumer offerings are positioned to significantly disrupt healthcare. China gets it because they have an AI health chatbot called Ant-a-Fu, which was launched in June 2025. It's already got 30 million monthly active users. And this is not being driven by hospitals or government, but by Jack Ma's Ant Group, the fintech giant best known for Alipay. Ant-a-Fu answers health questions, books appointments, interprets test results, coordinates insurance payments, and nudges users on things like medication and exercise. The service sits seamlessly inside Alipay, payments and lifestyle super app used by hundreds of millions of people in China every day. The app is ranked among the top 10 most downloaded iOS apps in China. And I understand there are marketing campaigns in subway stations, social media, public restrooms, even painted on walls in rural China. And so I thought this story just really validates a lot of our analysis, George, that we had in those two shows. But it also strikes me that this approach of having a super app ecosystem and your health AI bot, which does all sorts of things, lives within that ecosystem, I think that could mean that China is likely doing much better than the rest of us in terms of having connected health records and with a patient-first interface and approach. What are your thoughts on this one, George?
China. Did I say it right? Is that my presidential pronunciation? China.
Oh, that's right. Yeah, I haven't heard him say that for a while. But yeah, it is like that.
That big threatening country to our north, which we do a lot of trade with, yet we always are a bit skeptical about. So I've visited China 3 times. I have to say, every time I've been to China, I come back really impressed. Yeah, and I've been there probably over a 10-year period, and you've just seen an amazing transformation over that period. On my last visit, we actually did manage to get Alipay working. And back then, it wasn't designed for tourists. It was designed for locals. But with a bit of help from some of my friends over there, we got it to working. And I have to tell you, running around Beijing using Alipay to book a taxi, pay for a dinner, organize tickets for a concert, do your supermarket shopping, know where to find things. It was pretty impressive. That integrated tools architecture that Jack Ma's group's done, and there's a couple of different ones in China. There's WeChat and Alipay and a few others popping up. I think it's a really interesting and exciting adaptation of how they use technology. And it reflects the market, yeah? So I think I've commented before, I think you had a chance to meet George Kazunas when you were on the Gold Coast. He's been in China now for the last couple of months. He publishes a newsletter called Age-Friendly Futures, which we're happy to share the link to. He's actually spent a couple of months in China over the Christmas New Year period, and he's been blown away by what he's seen there over the last few months. The robotics improvements, the AI improvements, the user experience, stuff happening. So it's something we need to really keep an eye on. Now, when we look at healthcare challenges, China has many challenges in delivering healthcare, yeah, as we do in Australia. But the difference being there's 27 million of us, there's 1.4 billion of them. And like our good friend Charlotte Blees in her book notes, what we need to do is we need to think about what we're comparing these solutions to. Yeah? We're not comparing them to an idealized Dr. House on TV experience. We're comparing them to what's happening in the real world. And in China, primary care has a number of really significant challenges, purely because of the size, purely because of the way it's delivered. I read an article that the average consultation in primary care in China is 45 seconds. Think about that. Think about that. 45 seconds. Now, whether that's truly representative, but the reality is we complain about our 10-minute medicine. They have to really churn through. So the ability to use these tools to streamline that process, to triage in real time who needs access to what services, to send them to the right place at the right time, is a real positive thing for their system. And yeah, it's allowing them to potentially jump over and leap in bounds ahead of some of our systems. Now, we've got 1-800-MEDICARE down here. This may well be a good example of how that's going to work. While we saw the failure of Babylon in the UK a couple of years ago, that may well have been that the AI wasn't ready yet. There may well be some other issues there. But the reality is these AI tools are going to play a bigger and bigger role. And with the right governance, and again, we need to make sure they're properly evaluated. But this may well be an example of how primary care will be delivered in the future. And yes, people, you heard it here first. We need to keep an eye on China, because China is really where stuff is happening around the world. We've seen our good friends in America have done some amazing stuff over the years and over in Europe, but there's a lot happening to the north of us that we need to keep our eyes on.
Absolutely. And actually, that feeds into our next story. So, China's National Health Commission has announced a $2 to $3 billion national AI healthcare strategy. It aims to embed AI assisted diagnostics and decision support across its entire health system by 2030. It's 2026. Like, that's not very far away. This plan includes building unified health data infrastructure, scaling AI tools into primary care and rural clinics, and standardizing governance frameworks to support safe deployment. So while Western countries debate AI trials and regulatory sandboxes, and we are using it in a haphazard way at best, China is moving to make AI a routine layer of everyday care with population scale deployment, which, like you said, George, there's a lot of people in China. So this raises questions. And most prominently for me is that I'm thinking, are we watching the emergence of maybe two different AI healthcare futures? So one in the more Western countries is more cautious, incremental, incredibly highly regulated. And then the other is fast, centralized, and scaled. And both of which I think would have positives and negatives associated with them. What are your thoughts, George?
First of all, how nice would it be to be able to announce a strategy and then not have to spend all your time and energy trying to get it funded or work out the political deals to get it through Parliament, or compromising on it, or doing what they know as pork barreling. And those of you who aren't familiar with the term pork barreling, have a look at it. Look it up in Wikipedia. It has a very interesting history. Yeah, the ability to have a strategy and deliver on it. Now, there's a lot to be said. That's what a strong centralist government does. Now, my Greek background tells me that we need to remain focused on our democratic systems, but how do we get these strategies to be deliverable? And we've seen so many challenges in Australia where we've had good ideas. A strategy that was written 15 years ago sits on a desk for 15 years because the political will to get it through and the timeframes, and it doesn't fit within an election cycle. So there's something to be said. And I did remember saying many years ago that maybe we need to think about health at a broader aspect than a political term of 3 years. Yeah. Anyway, I'll give my credit to Effie Guo, who published the article, focusing on national infrastructure to enable large-scale pilots of AI tools in the real-world environments with the relevant strong regulation and governance. To me, sounds like digital health nirvana. To quote her in the article, infrastructure first unlocks scale that tools first never achieves. When you control the data rails, AI deployment accelerates exponentially. Sounds really exciting. To our previous point, there's stuff happening in China which has connotations throughout the world, and we need to keep an eye on what's happening over there. We need to work out how we can work more collaborative with them, because there are some amazing researchers in China. We know China has its challenges. Yeah, let's be honest, Australia has its challenges as well. We need to think about global collaboration. Now, small plug again, the Global Health Connector that I'm involved with is part of working on that project and getting countries around the world to discuss. And we need to make sure countries like China, and often we struggle to deal with a lot of the Asian countries that don't have English as a first language. Yeah, when you go to Japan, you see some amazing stuff in Japan, but yet we often don't hear about it because it just doesn't translate to English very well. So we need to work on how we get that collaboration happening.
Yeah, absolutely. All right, that's the end of our hot topics. So, George, another great show. Oh, my God, we have always just so much content to cover. We didn't get through all of it that I had planned for today, but always lovely speaking with you.
It's always a lot of fun, Louise. I look forward to these sessions. Yeah, they're great. I tell my family I'm locked away in my office with Louise for the next hour. Do not disturb.
Yeah, and sometimes I apologise to George's family. It's a little bit longer than an hour. All right, did you have any recommendations, George?
I'm just following on a recommendation you gave me a while ago to watch a TV series called The Gilded Age, and I started watching it recently, and it's really cool. And it also gives a view into modern day world. So whilst it focuses on 19th century New York, I suspect 21st century San Francisco has a lot following on from that. I'd highly recommend it if people get a chance to watch The Gilded Age. It's really entertaining.
Oh, I'm so glad you liked it. Yeah, I introduced my mum and my sister to it over Christmas, but it was like at the end of our Christmas break. So I think we watched 2 episodes together. And then my mum, before she went back home, was like, how do you put things on my iPad? Could you do it? And my sister rang her the other day and she didn't answer, and she sent me a text. She goes, I'm just on the last episode of Gilded Age. I'll call you back. So they finished all 3 seasons now. So I'm glad you and Marina liked it.
And there is a 4th series coming, they tell me.
Yes, that's going to be good.
What about you?
I have a digital health related recommendation. So Sara Rigar from Sweden, she is academic. We need to get her on the pod, actually. Sara's amazing. And anyway, she also has Parkinson's, and she took such a scientific approach to living with Parkinson's and doing her own research, working out what medication dosage. She's turned it into an academic pursuit. And anyway, she's so impressive. She published a post on LinkedIn recently called "Why Are Patients the Only Ones Around the Table Expected to Work for Free?" And the article was about how to appropriately engage with patients on research, care improvement, conferences, products, etc., and payment being one of those things. As that article was so popular, she's now created a checklist and resources for meaningful engagement of patients. So I'm going to put a link to that checklist. So whether you are a patient or you work or a consumer carer, whether you work with people and do engage with consumers and carers, check out Sarah's link. I think there's some really good content in there that's worth considering and maybe adopting into your policies and processes when you engage with patients. So I'm going to put that in the show notes.
That's really interesting because, again, we keep on talking about patients in the center. Patients in the center for free is not a scalable system, is it? And we're not talking billions of dollars here. We're talking enough to support them. And also, I think the other important thing is also that feedback loop. So what we learn from patients, how we feed back to those patients, what we're doing with the information that they're providing us. So I think that's really interesting. Looking forward to maybe having Sarah online soon.
Yeah, no, that'd be great. All right, George, you've got to head off to the airport soon. But before I let you go, if you could please read us out.
Sure. Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Emily Mara for her support. Big thanks to everyone for listening. Make sure you subscribe, follow and rate us wherever you get your podcasts. Visit pulseit.news to catch up on the news from Australia, New Zealand and Ireland. Send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. See you when I get back from Europe.